would like to welcome you to the Rome Intended World Conference of WIP. I'm Gabor Racz, former president, founder, and board member of WIP. It is, while regretful, but we need to do this to do some upgrades. And it is my privilege to have been given the opportunity to talk to you for about 45 minutes about updating neuroplasty and to give you a healthy view of what neuroplasty represents, and I hope I'll be able to do it. But there is a learning curve, and even if you start for the first time having heard about it, it's never too late. You can catch up extremely rapidly. The literature is extensive, 70-some papers already published, and not a single serious negative one. So anybody claims there is no evidence, they just need to look rather than say without foundation. The evidence is remarkable, and I understand that Ludger Gödesmeyer, who actually produced the best paper on neuroplasty, which was published in 2013 in Pain Physician, which is one of the really significant pain journals, and certainly for interventional pain, one of the best. I was invited to a neurosurgical treatment of pain conference, and for my total pleasure, I ran into Professor Hitchcock. And here is the picture of Professor Hitchcock on the left. I am in the middle. I had a bit more pigment in my hair. And Bill Sweet, who is the John Bonica equivalent of for neurosurgeons of the leader in pain. He was the one that was really the first one to do radiofrequency lesioning of the Gasserian ganglion for trigeminal neuralgia. And he was physically present. And Hitchcock, the one on the left, is the one that introduced subarachnoid iced saline by freezing saline and then taking the fluid underneath the ice and barbitized it into the subarachnoid space. And it was in the time when we really had not very much in treating patients. And I actually, as a young faculty, with my mentor, Willie Evers, did one case which was a general endotracheal anesthesia, sit the patient up, do a subarachnoid block, get the ice saline from the refrigerator, and we didn't know whether it was the hypertonic aspect or the icing aspect. And then a year later, Hitchcock published from 67 to 68 a first paper where he did not talk about hypertonic saline being a neurolytic. He was talking about the consequences, and the consequences that he listed basically were hypertonic, twitching, and warning people that these patients need to be watched and controlled, and they eventually settle down and then go home a year later a day later from the hospital pain-free. And this was pretty well the story of our patient we did in 1968. Patient did extremely well. I did not think of using, but at that stage, this was the first paper published in the Lancet, which is one of the very significant publications worldwide, and a year later, again in '68, they published the second. Now, I was by then working with Dr. Hevner, and one of our concerns before we went to patients was, is hypertonic saline a neurolytic? And what you are looking at is compound action potential tracings, and the first line is control, and 5 minutes after 10% sodium chloride bathing, you can see the suppression, washing away the hypertonic. What you are witnessing here is the nerve recovers. Well, what it means is that it is most definitely not hypertonic. Otherwise, we would have large numbers of paralyzed patients. That there are patient problems if the technique is not followed, but not otherwise. I want to show you what we've learned, and there's no better way than, this is actually verifiable because it's in the first edition of Techniques of Neurolysis book in '89, and this procedure was done in '86. So at the time of publishing, it was already 3 years over the procedure, and the patient was doing great. In the beginning, we did do the contrast. I learned from John Lloyd in Oxford, England, the use of hyaluronidase, and that has been a tremendous addition. And we've learned more activities about hyaluronidase, and then put the local steroid in, and then wait 20 minutes. Because if by chance you are subdural, it takes 14 minutes to get 14, 15, 16 minutes to get a motor block. Unfortunately, there is one paper that they waited 5 minutes for a transforaminal hypertonic, great results, but there is a low incidence of sharp needles going into the nerve root, and you can spread in any one of the components of the subdural, subarachnoid, or the intracord, where the injection of a solid is going to cause the problem, or the normal conversion of a hypertonic fluid through semi-permeable membranes. The volume expands, and the pressure from the volume can also cause serious problems, such as cutting of circulation, ischemic necrosis. But there is a warning period, and we published in several publications, textbooks, that if you have a subdural spread, first you get numbness, pain, motor block. You must look on the lateral view. When you look on the lateral view, you will see like a sausage within sausage, spinal fluid clear in the middle. And what is uniquely interesting, that the subdural space is a space that you can drain. So I had one of these. One of the residents wanted to show how smart it is, and before I could get into the room, he already injected the hypertonic saline. He didn't listen to anything, and the patient was complaining of bilateral leg pain. I looked in the lateral view. I could see the contrast outlining the subdural space. So we took a spinal needle, interlaminar in the midline, stick it in the subdural space and aspirate it out. Now, as soon as I got 13 cc's of volume out, patient says, "Oh, my pain is gone." So if you have loculation and you do flexion rotation, or if you do flexion rotation, if you have a thoracic or lumbar subdural, you may milk the volume injected out over a larger area, and you may actually resolve the problem. And we published on this very issue in Pain Practice, and it is one of the original. It's starting a whole new branch of cases, and the title of it is Collegial Communications, and I suggest it's worthwhile looking at if you get heavily into this topic. Just look at my name, and I describe how somebody calls me for help. Patient still is in the operating room, and we resolved it without any surgery or any additional problems by flexion rotation and distributing the pressures, and the patient regained a motor block. Now, looking at this first ever published lysis case, rotating injury, develops slowly, tremendous scarring on the left-hand side, and it seemed logical when we published the first publication, Techniques of Neurolysis, that we put the issue of is it a neurolytic, and documenting the evidence and several tracings of compound action potential recovering, and also the issue of loculation has been published elsewhere, but you would have to look for it. So here is the next picture after I saw the in '86. I tried to get to the left-hand side a bit better into the ventral lateral epidural space, but the quality of the catheters were not good enough, but I did about as good a job as I could, and you can see the Christmas tree appearance already coming back, and the patient had a tremendous response. And then instead of just taking the information, we puzzled because he didn't have surgery. We did not know about scar formation without some trauma or surgery. And what we got out of it, that we decided that this patient had an L5S1 herniation and bulging disc, and wasn't bad enough certainly to explain the pain and disability, and the neuroplasty is starting to open up, and we injected more volume, the hyaluronidase, and the patient did dramatically well. And then we did the obvious, did discograms with Rick McCarran, who was the surgeon, and the discogram showed the leaky disc, and you can see as I push the hyaluronidase has a spreading factor and inhibits neutrophils. Two excellent papers of not very long ago. People that haven't read it, they say hyaluronidase has no effect. Well, that's nonsense. Hyaluronidase has lovely effect. It prevents the inflammatory cascade by inhibiting neutrophil infiltration, and you will see that later. So here you could see that we opened up the area, and then we used the hypertonic saline 3 days in a row, once a day, and exercise, physical therapy. And then following that, we scheduled him for a fusion surgery by Rick McCarran after getting the information. So Ludger Gödesmeyer, who will talk separately, he has the best ever study, and he recommends neuroplasty before surgery. Now, the patient lasted, it was a 360 fusion. You can see the hemoclips in the patient's abdomen. 22, I called him 20 years later, and he reported he was doing just great. Then what happened was he calls me that he's in tremendous pain, and we repeated. He came all the way from northern Midwestern state, and I deceived myself. If you look at this picture, on the two-dimensional picture, just in the AP view, the fusion is holding, but he had tremendous pain, almost couldn't move, and he scarred back exactly the same area as before. Now, the answer seemed, we go back, and I was very proud of myself because see the catheter going to top of a L5 nerve root, and it's curving out into the neural foramen, but there's not much coming out through S1 and going up to L4, so that this looked bizarre, and we did not know enough. What this next picture reveals, actually injected more, and you can see there's some contrast escaping over the L5, but not so much the underside and S1. S1 is not really opening up well, and he did very well for a short time and not very well later, and he was unhappy with what we could do for him. And when we looked in the lateral view, this is the problem. You can see the catheter going in the posterior epidural space and missing the ventral epidural space. And the ventral epidural space, on the left-hand side, you can see the catheter curving down. And that's the problem. And this is what we did not know. I had no idea about this because the contrast looks like spreading, but it doesn't show what I was saying earlier. And this is exactly where the scarring triangle is. And I should have been following the epidural space, and unfortunately we didn't. So he was very unhappy, and everybody until Tomikichi Matsumoto, he's a professor in Japan, uh, came up with the idea after almost in the novice state, where for some reason he came in with an RX Coude-2 needle through S1, and he was able to get beyond the disc in the ventral epidural space. And if you are looking at the sacrum, it has a curvature, and if you come up, the curvature and the scarring ahead of it, it prevents the catheter from going in a ventral epidural space. It continues posteriorly, and then I curve down over the L5 nerve root. And that is one of the weaknesses if you don't look at the ventral epidural space. I want you to look up a very important study by Kozlich. Kozlich looked at what hurts in the epidural space, and the most painful structure by mechanical and electrical stimulation in a large number of patients, where he did the laminectomy under local anesthesia, and he found that it is the posterior longitudinal ligament that hurts the most. The nerve root hurts, facets don't hurt, muscles don't hurt. Facets hurt if you move it, and you have the run into the secondary muscle spasm. So this is very important that you look in the lateral view, and if there is no opening up with the catheter, then you have to come in with a second catheter to mid-canal, and then I go with 5 ml contrast, 5 ml hyaluronidase, 5 ml local and steroid. Now that will get rid of not only radiculopathy pain, but also back pain, because back pain comes, you will see this at the end of this presentation, mainly from the sticking down of the dura to the posterior longitudinal ligament. So this is what I tried back in 2008. 22 years later, the patient came back. I could get up with the catheter in a nice straight line from the sacral hiatus, but we did not know about the scarring triangle, which is above the disc, below the L5 nerve root. So here, to open up the L5, L4, and down into S1, I put in a transforaminal catheter that goes in rather nicely, and it opens up the underside of L4 and top of L5, and I was very proud of it and happy. But now I would not be proud nor happy, because we need to open up the ventral epidural space. You really need to look at the opening up. We again looked at the effect of the hypertonic, and here you can see the compound action potential being wiped out in 5 minutes, and then we increased the gain of the recording device. After 20 minutes, it comes back and going back in gain to similarly to what was original. You can see the nerve is recovering after about 30 minutes. And that's what our clinical experience is. And people that don't bother to look at the evidence, they just say, oh, hypertonic is neurolytic. It is not so. the nerve recovers, and we have literally millions of patients now where hypertonic in the epidural space was introduced. And one of the problems have been a painful hypertonic, and now if you look at PainCast, you will see the exact dosing for how to avoid the pain of hypertonic saline. You can do it pain-free by a pre-administration of, in the caudal epidural space, 1.5 ml of 1% lidocaine, and then we use the dilution to the 10%, not normal saline, but 1% lidocaine, so it end up with injecting 0.6% lidocaine before the hypertonic, because that will test you for motor block. And you really have to be careful for the first 30 minutes or so and not let the patient stand up, because the legs can buckle during the observation period. But what we gained by addressing the issue of hypertonic is cost effectiveness in not having to do 4 hours of observation afterwards, by cutting back the bupivacaine to 1/8% for the second and third dose, and we can compress the requirements to twice a day the first day and once in the morning, and within an hour the patient can get up and walk to the bathroom and void. So paying attention to the concentration and exactly how to do it, please look at the PainCast description of the scarring triangle procedure and paying attention to the dosages. So this is some of the things that is new and very significant, because the outcome still is measured long term. Now, the patient inclusion criteria, spinal stenosis. Now, this is fascinating because there is a series of surgical resolution of spinal stenosis, and because they open up the stenotic level, the dura, where if it is in the mid-lumbar areas, and you open up, the dura and the nerves pull on the segment that is stuck down in the scarring triangle or anywhere, and you can cause a traction-related spasm and ischemic changes in the innervation of the bladder. And if that happens, you have bladder dysfunction, bowel bladder dysfunction. And this series of patients, it was something like 430 cases of surgical spinal stenosis resolution of the stenosis, and that 26% ended up with bladder dysfunction. Well, you may shift the blame to the patient, but if you measure it, there is a significant bladder dysfunction. And when we ran into this, one of my patients, the patient couldn't pee, so she had to, an 80-year-old lady, had to catheterize herself a couple of times a day or 2-3 times a day. And then we come in and do the S1 scarring triangle and open up the area that the stenotic area being freed up is pulling on it, causing traction ischemia. And I went in, reversed it, and within 24 hours, the patient had regained normal ability to urinate. Facet pain, well, it is because a facet pain implies either injury or derangement or something to the facet joint. But remember, the medial branch comes from a nerve root that may be damaged inside the epidural space. You could have scarring, and opening up the proximal aspect of the nerve with freeing up the nerve root or nerve roots. The simplest and the most long-lasting way is going in with maybe, depending on whether you have positive straight leg raising or a dural tug. Dural tug is when you bend forward and then go as far forward as you can, and then you move the head and neck, and that moves the dura, and it's amazing how much it moves. If you want to understand this concept, you really have to go to Paincast and look at one of my patients who had 3 electrodes placed at C2-3 area. And when I was doing during a neuroplasty, the flexion rotation to open up the size of the cervical neural foramen to have lateral runoff, I could see the 3 sets of electrodes placed by one of the finest for a different reason. Because the problem, she came to me with C6 radiculopathy, and she had the 3 electrodes up at C2 area from atypical facial pain. Osteophyte and radiculopathy is remarkably effectively dealt with neuroplasty, because the painful nerve root from the irritation by the osteophyte causes swelling, and you get the swelling out with the hypertonic as well as the hyaluronidase and the steroid a couple of days later kicking in, and the nerve root shrinks inside and settles next to the osteophyte. So it's easily explainable. Failed back surgery syndrome. One thing we learned from large series that failed back surgery syndrome can give rise to significant scar formation. And you need to do the straight leg raising and full reflexes as well as a dural tug, and the patient will help you to tell you where the pain is. This is multi-level degenerative changes, and there's a trap in that if the pain comes back when you have multi-level degenerative changes, the pain usually comes back 3-4 years later, maybe 3-4 months later, on the opposite side or at a different level. And this is why you have to establish the diagnosis accurately, to know what level you are. It's not that common unless you haven't done a good enough job for the pain to come back at the level where you go in. And this is the trap for the surgeons, because they make most of the surgeries based on morphological changes and not necessarily on physiology or physiopathology reasoning secondary to scar formation. Lateral recess stenosis and radiculopathy, spondylosis and radiculopathy, that's tough. And oftentimes you can clear up around the spondylotic segments, but I've had several cases where you you really end up and need to do a surgical stabilization of the spondylotic segment. Pain unresponsive to spinal cord stimulation, very much so, and probably should have a neuroplasty in all spinal cord stimulation. And then you go after the leftover pain, if there is any, like a spondylotic segment, either have fusion or neuromodulation. But back pain has never been compared to spinal cord stimulation when you do neuroplasty. And I believe neuroplasty is much more effective than spinal cord stimulation because you can go to any level. You go in a ventral epidural space, and hypertonic saline disconnects non-myelinated C fibers. And most of the sinovertebral system is a lot of C fiber activity. You have other fibers as well, but the C fibers are predominantly in the so-called non-specific back pain. But this is something you'll have to be convinced, and I'm sure you will find the explanation when you go 22 years, when definitely single level pain, and then the patient develops the scarring triangle. If you don't know about it, you will have more pain, and you may go for a much more expensive treatment. Post-laminectomy syndrome of neck and back after surgery, absolutely true. And when you go in the neck area, you have to be really careful that you do not loculate. Radiological evidence of pathologies such as spondylosis, radiculopathy, epidural fibrosis, metastatic carcinoma, you gain tremendous pain-free periods instead of agonizing pain needing tremendous doses. I had a patient that was cured of cancer, but had secondary to the disuse and scarring, and he was stimulator, bedridden with pain, and he went fishing, and 3 or 4 months later pain came back, so we just repeated it and he felt great again. So it's a minimally invasive, very cost-effective procedure, and cost-effective studies definitely support its use. So chronic low back pain greater than 6 months, very effective by doing the proper examination to know what level the pain is. And I'll show you one of these cases in a minute. Exclusion criteria is just as important as inclusion. Spinal instability or syrinx, absolutely stay out of syrinx cases. I've seen paralysis just from loss of resistance technique. Patient refuses, sepsis, infection, drug addiction. If non-dependable patient, you should not do it. Adverse reactions, allergies, medical illnesses. If you are on antiplatelet medications, and these are very important, anticoagulants, NSAIDs, Plavix, aspirin, ginkgo, ginseng, vitamin E, and a list is growing, so you need to keep up to date on these. The standard volumes, I suggest you look it up in Paincast. This is the best study by Gerdesmeyer, but he will be lecturing about it, so you can look it up. The large number of patients from Korea, And they found that the good outcome really came from documenting transforaminal runoff. So now we go the ventrolateral epidural space and then do the flexion rotation, chin to shoulder, during the procedure. And to do a cervical neuroplasty, I suggest you put a small pillow, paramedian, direction depth, direction technique. But if you don't put a small pillow and you put the shoulders next to the patient, that raises the ligamentum flavum area, so you will have a perfect view. So it's a small trick, but I used to struggle with cervicals until this was totally recognized. The small pillow and put the arms next to the patient, then you go paramedian, direction, depth, direction, and I will show that again. There is another cervical large series in Pain Physician in 2015 using Racz catheters with great outcome. And they compared in this paper, patients that had surgery and no surgery, which group did better, and the no surgical group did better. Now, this is why they added 2 more faculty members to do the work, with a tremendous amount of work, to compare the epidurograms and with the venous runoff. And what they found that it is not so that the surgical group did more poorly, because if you do the flexion rotation during the surgery and you go to the ventrolateral epidural space, the patients that did the best are the ones that had transforaminal runoff. So you really need to get your technique, and you know, it's like greasy kid stuff when you look at epidural, single-shot epidural steroids, unless it's a single-level disease where you don't have massive scar formation at multi-levels. But you are an expert because you have to learn what is the best way. That is very, very relevant is the RX2 Coude needle, because if you move the needle in epidural space, you can cut the dura. And if you cut the dura, it can be very expensive. I have been in one case that was going for $60 million for a couple of wet taps. We managed to convince the jury that it was not really related to a technique, but wet taps can happen, but you can avoid it by putting a second stylet. If you look down in the catheter, the second stylet interlocks with the needle and goes beyond for 1 millimeter, and then you can spin the needle in epidural space. It's not going to do it, not going to cut it. Now you can see, you go in and you can see it 1 millimeter stylet protruding, and now we look at the scarring triangle, and it is the big trick of the Matsumoto technique is to use a tiny catheter that fits in along the concept. The bigger catheter doesn't fit into the opening in the scar tissue, but the smaller Versacath 21 gauge does fit in. So you can, by multiple trying into the appropriate tissue plane, to open up the tissue plane. And the indication for scarring triangle, look in PainCast, you will see this. And just let me show you, this is a patient who had transdiscal transforaminotomy, transforaminal discectomy, sorry. And at L5S1 the pain did not change. And the day before, I marked the pain by doing a dural tug. Bend forward and move the dura, and it pulls on the painful area. And the patient pointed at the day of the procedure, exactly the mark of the day before, and that was L2 nerve root. She had a nephrectomy years before, and blood leaked in, and the scarring happened. So here is another example of the pain in the thoracic area that you can now diagnose with the dural tug. This little girl, age 13, had a leaky T910 disc and could not move. They took out her gallbladder, it didn't change the pain. They took out her appendix, didn't change the pain. They told the patient, go and see a psychiatrist, we have nothing further to offer. Then she came to us, and then we found on MRI a little tiny change, but the pain was pinpoint accuracy like the one before, and we went thoracic T910, opened it up, and you can see now she can put her head and neck between her knees. And similarly with this patient who had a re-injury, and after neuroplasty he can also do. Well, the story goes on. We covered many, many aspects, and I would suggest look at the concept of the moving dura, concept of dural tug, the concept of examining the patient, and look at the lengthier presentations. What is the latest update? I believe we covered, but you have to learn to get the best possible outcome, and you will see many years of improvement. Or when you don't see the improvement long term, that is because the diagnosis may be on the other side or one level higher. But adding hyaluronidase in two groups of patients, it changed the outcome, and the absolute outright failure group from 18% in the no hyaluronidase to 6% when hyaluronidase is added at 12 months follow-up. And I wish you the very best, and have an honest look at your practice. Are you getting the kind of results I'm talking about? Well, I have been. It's nothing unique to me, but it is the fact of adopting what is the latest development, and all these procedures are published, and you can learn from it